Kia ora and welcome. I'm not just checking my email, but I thought that if the theme of this conference is epidemiology in the age of the internet, then I should refer to an electronic device, because you need one of these if you're going to use the internet. And also, I want to acknowledge Enigma Solutions Limited, because if you want to use the internet, you not only need a device, you need good software. And this session has been kindly sponsored by Enigma Solutions Limited. They're an Auckland company established several decades ago. I've been working with them for over 10 years. And they're responsible for the cardiovascular risk assessment software that if you live in Auckland or Northland, it's very likely that you've had a cardiovascular risk assessment using their software. So I'd like to thank them for sponsoring this session. And now it's my great pleasure to introduce Frank Sullivan, who has worked as a family physician, a GP, for 31 years. I didn't believe it when I saw him, he looks too young. He's worked mostly in Scotland, but since February 2014, he has been based in Toronto, and he's going to be there for a couple of years. He's the research chair at the Department of Family and Community Health at the University of Toronto, and he's director of Utopian, which sounds amazing. It's a practice-based research network at the University of Toronto. He also holds honorary posts in the Dalla Lana School of Public Health and at the University of Dundee. And his research interests since 1984 have been in clinical trials and in linking health databases for research. And indeed, his presentation today is on bespoke linkage and big data. But just to finish off, I should say that he graduated from the University of Glasgow in 1980. He was their most distinguished student that year. And he combined his clinical training with service as a GP, plus he did a PhD in clinical epidemiology. And until he went to Toronto earlier this year, he was the NHS Tayside Professor of R&D in General Practice and Primary Care and Director of the Health Informatics Centre in Dundee. So without further ado, I'd like to introduce Frank Sullivan to the podium. Thank you, Frank.
Thanks, Rod, and thank you all for that fantastic welcome. This is only the second time I've been in New Zealand, but that was quite an overwhelming experience, I have to say. How are we doing? We're good. Right. So yeah, that's the title, and I think I've been asked here because Robert Scragg was in Scotland last year and was looking at some of the things that we were doing using the internet, and he asked me to come to this conference because it was germane to what you're going to be thinking about the next couple of days, and I was delighted with the prospect of doing that. But it made me think, when's the first time I started to think that data was getting a bit out of hand? And this was probably it. I was doing my PhD in 1990, and Geoffrey Rose was bemoaning the fact that people were just collecting data without thinking about what they might do with it in future. And London School of Hygiene, they actually had just got a computer that could hold 9 gigabytes of data. Whoever would ever want to use as much data as that? You couldn't think. And he pointed out that the whole of the Roman Empire, the whole of the known world at that time, was run without the use of photocopier. He also noted that the Romans didn't have a word for subcommittee in the same article. So these are my perspectives of being somebody who produces data as a GP, and very aware that the old garbage in, garbage out in informatics is a two-way street. If you have useful software like Rod's Predict, then it's much more likely that clinicians will use it. They're getting value out of it, so they'll take the time and effort to put the information in. The kind of work I mainly do is trying to answer questions in primary care, but that requires informatics tools. We have to be able to access data, not just from primary care, but lots of other sources, and then also use smarter ways of recruiting patients and following them up. As he said, I was the director of the Health Informatics Centre in Dundee for a very long 7 years. And as part of that, I was involved with the UK's plans to make more of data in this overall committee. And so what I thought I'd do for the next wee while is to talk a bit about how we moved from bespoke linkage, as and when it's needed for a specific purpose, to the whole idea of big data, which has been around for a while, but has become prominent as a result of various business and political uses of it. And perhaps I could rephrase the big data question as, how did we manage to persuade the UK government and other funders to give us just under $300 million to work on this? And I'll try and answer that why they thought that this was a good investment. Does that sound reasonable? So Scotland then, deterministic linkage, which I'll describe a little bit, started off mainly in Tayside, became the norm in the whole of Scotland. Web services, using the internet to exchange data securely, was important for that, and regional repositories of data. It all started really back in the mid-70s when a director of public health, Ronnie Graham, took this fairly obscure idea of having a single number for every patient. So a bit like in New Zealand now, where you have a number for doing that, the NHI. He decided that this was something which could be used, and persuaded the professor of pharmacology at that time, who was interested in patient-level studies, that this would happen. And my first experience of this came whenever I moved from being a GP in Glasgow, where we had a health index number, but nobody bothered with it. You know, it was there, but nobody enforced anything. First morning in surgery, seeing patients, I sent somebody for a chest X-ray, and the radiology department wouldn't do it because I'd only put down all their other details, including date of birth, but I hadn't put their CAI number on. So that was it. That's all it took to change my behaviour. Now in Scotland, about 99.8% of all health encounters and various transactions have this number. And that is now seen as quite a good use of a pound, a good expenditure. And that is what it is. So it's a 10-digit number, not a 7-digit number like New Zealand has. But the key is having a checksum to stop doctors making it up, and other clinicians, but particularly doctors making things up. And as people come into the country, either by being born or travelling from exotic places like England, they are given a unique number, and there's a central register kept of all that, and people can be followed through. And it just means that you can take all those disparate sources of data and stick them together and make a picture of them. Now, this kind of idea isn't unique to Scotland, far from it. I mean, although there is this idea of taking data from prenatally right to the end, a lot of countries have this. And I would say that in Scotland that it's not a complete data set from the mid to late 70s. Things like birth go back to the 1850s. They're high quality, and other things like GP registration, the GP records, accident emergency attendances are much more recent. They're only able to really be used for the past, well, probably 10 years for GP records and 2 or 3 years for emergency room records. But it is possible to make that kind of use. In Ontario, where I now work, they have this Institute for Clinical Evaluative Sciences, which does similar work. Scotland drew quite a lot on the work in Australia. Don't know if there's anybody from Western Australia here, but a lot of the work there was quite important in informing things that we did. And I was hearing yesterday about New Zealand moving towards a much more integrated data infrastructure, making these administrative data sets available for research. I'm also involved at a European level with trying to make electronic records available for research purposes, for doing drug studies, which will be able to be submitted to the European Medicines Agency and indeed the FDA. And they're getting quite far with this process of taking the two electronic records as they are at the moment. Okay, this takes a wee bit more work than this, obviously. But the idea is that the electronic record, and already for some studies in this EHR4CR, which is burning through about 40 million euros in total, with buy-in from a lot of sources. So there is a way of doing it. The proof of concept is there, and I'll just maybe talk a wee bit more about that. The first uses, though, of the data in Scotland were pharmacoepidemiology. The early ones were the standard just for associations, then it became more hypothesis generating, and then started to be used for interventions. One of the first studies was just post-marketing drug surveillance, and then we're carrying on in that line of work, as many of you will be doing. This is another one that was just out a couple of months ago. It also starts to be able to generate a hypothesis. So this was a paper in The Lancet a couple of years ago just looking at comorbidity and the extent of it with various conditions. And you can see in particular the mental health being such a major comorbidity for so many physical conditions. And also when you compare affluent and deprived practices or groups of patients, you can see quite big differences just from the linking the data which is there to do with hospital admissions, GP records, and prescribing. One of the other hypothesis testing ones that we got involved in was looking at some things that should never happen. So patients should obviously never get a non-steroidal anti-inflammatory drug if they're already on an antithrombotic. But they do. In Tayside, the average was 4 per practice. And that obviously led on to a bit of qualitative work. And you could see that actually for quite a lot of them, there was a good reason for most of these patients. There was a choice between being able to go shopping or live independently and taking the combination of drugs, and people were happy to do that. But on the other hand, there was still a question about outliers. Once you start to get big data flowing through, you can start to ask questions. Well, maybe there is a good reason for why this practice is beyond 3 standard deviations, but maybe there's not. But what it means is having the data there, you can then ask the questions and persuade funders that there is a research question there, and you've got the pilot data to then design the intervention study. So this has been funded, a piece of work by the HTA to take that forward. And then sometimes it's just following up patients. Many of you know this WASCOPS study, and the first time that it was published, that was the end of the trial conditions, and that cost a total of about $30 million to run the trial. Of course, then with record linkage, to follow up for a total of 15 years, it cost an additional $30,000. Basically, a little bit of programmer time and a statistician to do the work that had already been set up. So the economic value of that big data record linkage is potentially huge. I was actually on the platform at the time that Ian Ford, who was the lead author on this, presented the data for the first time in St. Louis, and several people fell off their chairs whenever they saw the numbers. Okay, so I was asked to talk about, though, not so much about the research initially, as about how the internet was getting used for managing chronic diseases. And I've taken diabetes as the example. It's actually probably one of the ones where we've got the best worked example, but it is only one. I mean, there's a number of them. And I'll start off, first of all, just talking about the basic minimum of having management for long-term conditions. A register of everybody, a way of recalling them and making sure that they get all the important things reviewed. And then I'll touch a bit on how having all of that allowed us to do research, and then about patient-reported outcomes, which is one of the big issues, I think, for big data, something which potentially could overwhelm us, or we can work out ways to make really good use of it. I'm just going to get some water. This is Shona Brearley, by the way, the nurse who's actually mostly responsible for making the whole thing work. So making a register isn't a problem generally. It was reported in the BMJ in '97, used standard capture-recapture techniques, multiple sources of data to find out how many diabetics there were in Tayside. The challenge is really keeping it updated. And that, I suppose, is where the linkage and the web services came in, that over the decade that these data are for, you can see number of diabetics went up significantly. I think this is mirrored in most countries, at least westernized countries. And it was because there was, for all hospitals, a single diabetes computing system that they all agreed to use, and that was able to be linked to GP data, this generic importer-exporter. Actually, the architect for this is now working in Melbourne, not in Scotland. But he designed this, and it runs every night about 2 in the morning. A query goes out to each of the GP records. The data get taken out, and there's a series of algorithms take out the erroneous data, and then you just add compare the clean data with the previous export and take it into a regional repository. And this idea of having a regional repository seemed to be quite important. People were quite happy in Aberdeen to give their data to something which was under the control of Aberdeenshire. People in Glasgow didn't want their information going to Edinburgh. They wanted it to stay in the west of Scotland. And so having an overall way of linking it, but that the people could be reassured that it was being kept by people like them. And that led to this whole, it was called DARPS scheme initially, when it was just Tayside. And the web services, apart from taking from GP, was able to get from pharmacies, from labs, from the retinopathy screening service, and the data all became available as soon as it had been recorded. And that basically just meant, then what happened was it became national. Once you can demonstrate proof of concept and show that in one part of the country it's working, and then get another 1 or 2 parts, then the funders, the government in this case, allowed it to go national. And then it meant that everybody could start to be reviewed, and you could guarantee that the things that should be done would be done. It wasn't the kind of collusion of anonymity of the hospital saying these bad GPs aren't doing these tests, and the GPs saying, but they're going to the hospital, why aren't they doing the tests? It was possible to say these people weren't having the things that they had done. And that meant that you could do things like bear down on lower limb abnormalities. And this is association, not causation. But despite the fact that there were 2.5 times more diabetics, there was a 60% drop in the rates of amputation. The services weren't overwhelmed, and people could just get very basic interventions. You know, so how do you prevent amputations? Once a year, get people to take their socks off. That's it. There's not any high-tech marvel about it. The problem is having a register, knowing who's had their feet looked at and followed up if need be. And that means sending a couple of invitations, phoning. If the person still isn't coming up, a nurse goes out to their house, and tries to speak to them there. If they still can't get them, the doctor and the nurse goes out to the house. We haven't quite got to the stage of asking the police to knock the door down, but you can pretty well assure that everybody who needs to have their socks taken off will get their socks taken off. And then, because you've got all the data, you can start to think about other research uses. And pharmacogenomics was another fairly important thing in persuading the funders that there was some value here. Most clinicians will know that there's quite a variability, well, for most drugs, but this is the sulfonylureas for diabetes, showing that in some people they had a 7% reduction in their hemoglobin A1C, in other people it got worse. And this could then sort of be followed up with genetic studies, and we're able to look at what the genes were that were involved in this. And this led on to some work in the maturity onset diabetes of the young, and discovering young patients who were on insulin and very badly controlled, but they had a particular genotype which was going to be highly responsive to sulfonylureas, and they were taken off their insulin and given a small tablet a day. So it was only 37 people in the whole country, but for those 37 people, not getting twice daily or more injections of insulin was quite important. So that got the interest of a lot of more serious scientists, and then you start to get involved with more bigger consortia of people who want the data that you're collecting anyway, and that puts, again, more of a strain on the data infrastructure. So all of that is pushing us towards the concept thinking of not doing bespoke data linkage, but more big data approaches. And the other thing, as I said earlier, was this idea of giving patients access to their own information, putting up a portal where diabetics could log in and see, well, how are my results going? How does it compare against what it should be like? And that then also leads on to more social marketing kind of interactions, social networking. The patients start to advise themselves, but again, it's creating a lot more data. At the moment, that's relatively limited. The first 3 years, we only have about 500 distinct users a month, about 2,000 or 3,000 out of the 250,000 people registered. But it is going up all the time, and I think this is going to be one of the really big challenges as we get more sources of patient-reported outcomes to handle. And I'll come back to how big that data set is in a minute. So there's a lot of V's in big data. I'll concentrate on the three commonest parameters that people talk about with it: volume, velocity, and variety. And this is the promise. New England Journal had a review earlier this year about it, and saying it was about generating new knowledge, predicting outcomes, and accountability, which is very important, but it's also one of the threats for getting access to clinical data from clinicians. But it is something that we need to acknowledge and be thinking about, because obviously they're a key stakeholder in the whole process. Oops, go backwards. People are generally aware of this idea of all the efforts we go to monitor flu. For a few years, it looked as though it could be just forgotten about because Google was able to tell you what was happening with the spread of flu across countries. But then it went wrong in 2013. And it wasn't entirely sure why that was happening. And I suppose this is one of the drawbacks to do with big data, that you don't have cause and effect. You have correlation, association, but very large volumes of data. And that's the question, is how to make best use of it. I'll try and do that over the next 20, 30 minutes. But we'll bear in mind that predicting the future is difficult. Lord Kelvin was also a Glasgow academic who rose to great fame in the Royal Society, but he got several things spectacularly wrong. Okay, so the issue about volume, what are we talking about? Really, this talk will be, I don't know, 7 or 8 megabytes. The average X-ray, one X-ray, will be 30 megabytes. A single genome is now running about 725 megabytes. Data from a practice, a single practice, will be half a gigabyte. But when you think of the system that underpins My Diabetes My Way, it's 1.5 terabytes. And you can just see the multipliers taking one patient's genome, one practice's data, and how it's changing, and how one big data set. And then we remember that Geoffrey Rose is complaining about 9 gigabytes being far too much. So volume is one of the issues. Another one is the speed at which things are coming. This is how it's been up till now, where we knew the data was in the silo that we wanted to access, and we could squeeze it and get a little bit of the data out and keep an eye on what was going on and think about using it. It's kind of getting like this at the moment, where it's kind of hitting you in the face and you're not quite sure. And really, not very long from now, it's like this. Last year, the European GenBank deposited as many genotypes in one weekend as they had in the whole of their previous history. So that's the rate of increase. And this was the last slide of once all the data sets start to come, and there's no way it can be manually controlled. We'll need the machines to help with it. JAMA also had a slide which I thought captured quite well the issue about variety of data that might be useful for health. I mean, I don't think all the potentially useful sources are on here, but it's quite a useful way of thinking about it if you want to go back and look at the May edition, May 22nd, of JAMA. And it's pointing out really that there are so many different kinds of, so many different kinds of data which we can be thinking about, and they're in different silos, and they vary in how accessible they are. They were mainly talking, because it had a United States perspective, of probabilistic linkage, but I think in Australia, New Zealand, and the UK, we cannot add, we have to do some probabilistic linkage, but we can also do deterministic. And they've also pointed out that there are some things that you're never going to get down to person-specific data. But a lot of this can be linked at a person-specific level and get away from ecological fallacies, etc. Another slide that Carol Desitu gave me was this. This was when we were working up for the OSCAR, the Strategic Coordination of Health Research. She was asked to say, well, what data sets would she need for her research in infertility and artificial reproductive technologies? And you can see that it's not 2 or 3. It's large numbers of data sets that you would have to be lining up ready to use, or go back every time in a bespoke way and ask for permission from all these sources each time that you want to use it. And is that the right way to go? Not guilty. So the last part then, I've said it is variety, and this is one that Ian Diamond, then head of the Economic and Social Research Council, put up as a talk for those of you who are interested in obesity, the known pathways of things which affect. Obviously, you're not supposed to read this. It's just how complex it is. It's worse than the Krebs cycle that you had to learn at medical school, many of you. But on the other hand, big data can also make things easier. This is a study where I was involved in, that published in The Lancet last year, showing that you could make around about a 7 or 8 kilo difference to the weight of middle-aged obese men. very few studies had done up to then. And the key part of it was the smartphones, a gadget, something that the men, when they went back to the classes, could share with their mates and say, look at that, 11,000 steps on average last week. And his mate would go, ha, 11,500. So for the next month, he'd be out walking around the block with his wife and the dog another 3 times to make sure that he beat the guy the next time. So it was effective, and the changes were sustained. But the data coming in from these things, we're not really thinking yet about how we're going to use them. But patience, this smartphone is actually the mock-up of what Apple say that they're going to be putting out as this Apple Watch. And of course, I thought nobody here would be interested in football, so I thought I'd point out that there is now a rugby union, fitness and training, sale in the UK, and I'm told, I'm not sure which, New Zealand clubs are trying to get there. Are there some overweight rugby supporters in Australia and New Zealand? Anyway, the idea should be generalisable. So there may be some research opportunities coming there. The EU have just funded an extension of this to football clubs in Italy, France and Portugal by about 20 million euros. And this is another thing to do with big data, that if we think about each of the enhancements to what computing can do, it doesn't double, it multiplies by 10. Everybody now has a smartphone. Very soon, everybody will be having these Google Watches and Google Glass and Apple Watches or equivalents from other companies. And the data will be being made available. And patients will be expecting it to be used for making decisions about their health. And I don't think, with bespoke linkage, the point is I don't think we're ready for that. And we're getting to this point where it is possible to flip from that industrial age medicine model to the one which was suggested 20 years ago about information age. That, although that was a concept then, it's becoming a reality around about us at the moment, as more and more people are starting to use the internet for self-care, using not just friends and family, but extended social networks, and looking to professionals, either for specific knowledge or technical skills. But the idea of it is that it's going down all the time. And this may, of course, be really helpful when it comes to managing the problems of funding health services these days. So let me turn then to how the Scottish Health Informatics Programme has changed into this bigger UK-wide scheme. I'll talk about just its core elements and some research applications. And I think one of the key issues is about proportionate governance. A lot of the technical issues are not really that hard in terms of anyway extracting, transforming, loading data, the classical informatics challenges. That's all relatively straightforward, but the governance is a challenge. And then talk about how the FAR Institute got that nearly $300 million investment and kept people on board. So this is what bespoke linkage looked like when we were starting off with all of this. It was really quite labour intensive and really slow, and actually quite often difficult to predict what you were going to get because of data cleaning and incompatibility issues. Even though we were trying to standardise processes in the Health Informatics Centre, we were having to employ more and more people to do the task and charge people more and more to be able to do the task that they wanted. And of course, researchers don't want to be doing all that. They just want, give me the data. They want to be doing the hypothesis generating, hypothesis testing work up at the top of the pyramid. They want somebody to take away all this messy stuff down here, getting the files, transforming it all, running simple queries, adding in other data sets beyond the clinical ones. These were all the whole range of things that we thought that we couldn't really carry on with what we were doing. And so we applied then for the funding, mainly the Wellcome Trust with some other funders, and Darcy Holman and a few other international people. So they joined the advisory board about how we would go about this. We couldn't come up with a single unifying diagram that got all the elements of the programme together that looked like a ship. We tried, but we came up with more of this kind of Greek temple of an overarching governance and engaging researchers and the public and the pillars of different clinical trials, and underpinned all the while by provisioning the data sets, the key part of data linkage. But we did manage to get a few ships into the individual parts of it. So these are the core: provisioning the data sets, getting the governance right, getting researchers starting to write it into their grants that they're going to use SHIP, and crucially keeping the public, or publics, engaged in it all. And then the projects themselves were a bit more nimble and carried out over shorter periods of time. But we're able to give the use case examples of how it was all being made to work. So that was the overall vision, improving accessibility. We had the data, but it was making it accessible and providing metadata so that people who weren't familiar with data sets could find out what was really in them, what the provenance of the data was, and how reliable it was likely to be for the purposes that they wanted to use it. Trying to get the processes right, getting local access. A lot of the kind of work that was before SHIP was you had to go to Edinburgh and sit down and do the analysis and take it away on initially a floppy disk and then a CD, and just make the whole thing better and create a national service. But crucially, I think, the last thing was creating a community of practice. There was some discussion yesterday about New Zealand having a single entity which was an umbrella for all this kind of work. And certainly in terms of Scotland, with a similar population size, and maybe it would be the same with some of the Australian states. If you get everybody working together across the different interested parties, then it's a lot easier to persuade funders that they should invest in the whole thing. And also, people with good ideas aren't just in Dundee. They were in Glasgow and Aberdeen and Edinburgh and Stirling and everywhere. If they had ideas and were good people to work with, and I think that was really the key thing that made it all work. These were the actual physical things that were developed in SHIP. An indexing service so that the different records could be assigned numbers that we could then use, a safe haven that I'll describe in a bit more, and a linkage agent for doing that. And then, as I say, crucially, the central national capability was mirrored across the country as well. Safe havens, so this is how the linkage goes. I'll talk a bit more about this in the workshop that's on tomorrow, but the way that it happens then is that data sources send identifiable information with people's names and addresses and securely to an indexing service. And the indexing service sends them back a local identifier, which has got a study number on it. And they then attach that to the data, the payload data, and send it back into a safe haven where the linkage happens. So if we go back, you can see that the people who've got the data source are allowed to have it. They are the genetics clinicians or the gastroenterology service or the laboratory. They're allowed to know who the data is for. The indexing service is set up in a way that it's a trusted third party. They don't do any research. They're not going to use the data. All they're going to do is to attach the study numbers. And then once that's been done, the data sources can then send information to a safe haven. So the safe haven never knows identifiers. And I suppose that was the key step to persuading people that we could put data together in a way that was likely to be safe. And at the same time, the work was going on about describing what safe havens were, which most people think of as an environment, somewhere where the analysis can happen in a way that minimizes risk. And it's not just the environment. I suppose the key thing is that the projects have to be safe. You have to be looking, first of all, that the work is not intending or unintentionally going to cause problems with confidentiality for people having their information put out. The people who use it have to go through a series of checks. Anyone can, but they have to create this. They're not just asked to attend the course, you have to pass the course, either by going it or doing it on the web. And the sanctions are quite severe for the individual and for the institution. So if someone in the University of Edinburgh breaches the conditions, anybody at the whole institution will be stopped from using any data from the SHIP programme for the next 2 years. So the institutions police it to a large extent. The data are made as safe as possible by a number of steps, putting categories together, this idea of top and bottom recording, switching things round, over-imputation, just making sure that people don't get the whole data set so that they could run queries that would allow them to work out who individuals were. The settings when people get in are through at the most secure and dumb terminals, and nobody has any recording equipment, no memory stick, no CD, no internet access, and not even any pens or pencils allowed in. But in some circumstances, it can be used with less security, and I'll come to that in a second. The last part of it is the safe outputs, that before anyone can take data out of a safe haven, it's got to be checked by someone who's trained in safe disclosure procedures, because they have to pre-specify the number of people allowed in a cell, for example. And this is the point I was going to make, which is about when do you have to go into a windowless room with no recording equipment and be searched, and when can you sit at home in the evening and analyse the data? Well, that's where it comes down to proportionate governance. And this was the crucial part of getting the lawyers involved before we went to court. This was in designing the system in a way that would stop us ending up in jail. I was obviously very keen to avoid ending up in jail. And they had this paper which was kind of widely accepted. We had a lot of consultation about it. And the idea really is that you set up a 3-stage process. You declare what the benchmarks are, that you then carry out a risk assessment, and the last stage is putting things into a category of from 0, where there's really no restrictions. It's actually publicly available data, and there shouldn't be any problems with anybody getting it, up to the category 4, where you do have to go into a windowless room and not have any recording equipment, etc. And that assessment, it's just all very clear-cut what needs to happen. I was on the Privacy Advisory Committee in Scotland for the last 2 or 3 years. In fact, I was the only doctor on it. It's mostly members of the public. That only met twice a year and looked at 2 or 3 cases. Hundreds of studies went through just with a civil servant looking at it and saying it was easy to fit them in to the different categories, and the researchers accepted it. And the whole thing then developed this national service called IDRIS, where anytime a researcher wanted to come for anything involving national data, there was a single point of entry, and they got assigned a named person who would help them through. Because obviously researchers will typically only come every 2 or 3 years, really active ones, like some of you might be 2 or 3 times a year, but it's still an unfamiliar task. Whereas the service, it's something that they're doing 5 or 6 times a day, responding to queries. And so they can help with the study design, because sometimes things that people want to do just can't be done. They'll give all the information about coding terminology. Crucially, and I put this in bold, agree deliverables and timelines. Researchers really like that part of it. They know they're definitely going to get their data at the end of November. No ifs, buts or maybes, and the service agrees to do that. It helps with linking to the data suppliers, which is variable numbers of, and then there's all the issue about getting your ethics, etc. So they help with doing all of that, and eventually the person gets their data. That's at national level. At the local level, there's often one person, say in Dundee, who'll be a research coordinator, and they will provide advice. Because actually most studies are more local than national. Maybe not for this audience, but the ones we were dealing with was very often clinicians who wanted to run queries, and so just accessing their local data. They would still have to do the training before they would be able to get access to the data, but a lot of the rest of it would be done quite straightforwardly. And that was really how we got on with SHIP. And it seemed to be working quite well. And then the FAR Institute was being mooted as part of the UK revamping the whole of this informatics. And FAR was chosen really because it is a very much an epidemiology scheme. There are other people like myself, GPs or genetics people involved, but really public health have got the lead in 3 of the 4 main centres. The folk who are interested in doing all of that. And so when it came to a vote about who to call it after, this father of medical statistics was chosen. That's its vision. Quite ambitious. It's to try to do large-scale research, not for just wee projects. It is a distributed research institute, which takes the 4 centres, which I'll show you in a minute, and it has this idea of just accelerating everything that's going on, and the NHS being part of it, a core part of it. It's not an academic entity, and it's open to working with industry, and it's about making the data available for anybody wherever they are in the world, as long as they can adhere to the governance. There's no restriction to it being people in the UK, so there will be opportunities for people here to access the data. I say I was in charge of the Dundee Centre, which actually led the bid, but really working with all the other groups in Scotland. That Ian Buchan led the northwest of England grouping, Ronan Lyons in Swansea, the Cypher, which was initially Wales, but then spread into the west of England, and Harry Hemingway leading the group in UCL, with all slightly different areas of interest. And what happened was that there was a call for a total of about $40 million from led by the MRC, but with other funders. And these 4 centres, say Scotland, Manchester, London and Swansea, each won a bid to get around about 10 million. But having got that money, the crucial thing was then to leverage it and get the additional 250 million. And that was achieved. That because of the track record of what had happened and people seeing that this was something that would have to be done, they went out to the various groups around the country who could contribute, even though they weren't in the 4 centres who had won the bid. Again, the idea of having a community of practice, people working with the best people they could lay their hands on. And the politicians thought it was wonderful. This was the 1st of May last year. And he was talking about revolution rather than evolution. It was good to have a politician having that. Obviously, you have to be careful. Politicians are saying something as positive as that about expectations and what they really mean, but it did make it a bit easier to get some of the additional funding from other bodies. So that's what's happening at the moment. There's a series of actual physical centres being developed around the country. A new build in Edinburgh, a refurbishment in Dundee is the two main centres in Scotland, but each in London, it's on the Euston Road. They've used funding to just next to Euston Station. For those of you who've been there, across from the Wellcome Trust and the MRC, they've got a whole new big informatics centre, developing safe havens, getting the infrastructure for moving the data around the country, getting new ways of accessing the data, and communications so that people don't have to travel around the country and clog up airports and drive up and down, causing more pollution. A lot of this is being done using a lot more newer communications technologies, as you would expect. And it's not reinventing everything. A lot of the tools that we would think about using have been developed. This is a group in Boston who developed this I2B2 application, where there's a series of open source, what they call cells, that can interlock to carry out tasks that you would typically want to do with phenotypic or genotypic data. And say it's free. There is an effort to mastering it, and you might have a better way of doing something. But there are some things like just identity management, which when you have the same people in lots of different data sets, if you had a bit of software that did that for you, how wonderful would that be? Well, actually, these guys at Brigham and Women's have already done that. And you just need to set your data sets up in a way so that it can make use of that. Again, it's the internet. It's not having to develop whole new IT applications. It's web services like the Genie application was. And it can be automated for some purposes if you've got the permissions to make the linkages, or it can be done manually if there is an analysis that hasn't been thought of before and hasn't been programmed. But again, you would then make the code for that available, and other people would be able to use it. The whole idea is to link with really big players. The European Bioinformatics Institute has supported this. The GPRD, as it was now, CPRD, which is going to have all the GP records in the UK on it. UK Biobank with 500,000 people with baseline phenotypic and genetic data, and accessing the NHS's data sets. The idea that we had in Scotland of proportionate governance has been accepted at a UK level now, and a lot of the sort of really smart computing scientists have started to be involved in doing it. Methodological developments. Some of you might know this work by Paul Burton, where you don't actually take data away from where they already exist. You get software installed in the different data sources, and you only output the analysis. So that's a new technique, which is compute intensive, but is seen as being a lot safer. And for some data sources, say like forensic psychiatry, who are very reluctant to give anyone their data, or income data people, then you can use newer methodologies. Maybe you don't need the data. Maybe you actually just need the output from the data sets to be able to do the work. So this is the way that kind of working at a national and now international level becomes important. These are all the things which FAR has been doing up to now. It's been trying to get the leadership and doing research to show the value, because it's all very well talking about the theory, but when you show a 60% reduction in diabetes, lower limb amputations, people get what you're talking about. It's not theory, it's not equations. I think some of the key part of it is, as I've said earlier, engaging the public with this, making sure that it's seen as being a valuable thing, because you know that there will be problems of some kind. Hard to foresee what some of them might be, easier to foresee other ones, like the government selling the first lot of data to insurance companies. We didn't really see that. We thought that they might want to do things that we didn't want them to do with it, but selling it to insurance companies was one that we hadn't really thought of. Getting the infrastructure sort of harmonised across the whole piece to make things more efficient. Getting industry involved, that makes the politicians keener on it, because you're talking about jobs and economic impact. And I think crucially thinking about training, career development. Swansea is the big lead on this in FAR. They're running many courses, because one of the critical parts of this is that there aren't enough people trained in the big data methods. I've seen lots of young people in the audience here. If you're looking for an area to go into, this is definitely somewhere there's a definite skills gap and likely to be employment opportunities across the world. And that's what it looks like now in Dundee, our bit of the FAR Institute, about how it's all meant to work. And I will go into this in the workshop, but for the moment, I'm just going to say this is the key part of it, that we've got permission for many data sets to have persistent linkages, or data marts is another way that people describe it. A gradually increasing number where the data controllers are sufficiently reassured that they will allow for a year or 5 years, subject to regular reporting back, their data to be linked. And it means that as soon as a query comes in, you may be able to get access to the data. Not as soon as the query comes in. The query clearly has to have been approved by within the regulations for privacy advisory and have ethics and these kind of things. So you can't just think up an idea and ask for the data. But it's a very short gap. It's not months or sometimes years that it would be with bespoke data linkage. Very often it's possible to run the analyses really quickly. And we think that this will deal with some of the challenges that there are in big data. The ones in black are the ones which a New England Journal paper this year said, and I've added on the two blue ones. So data standards are still an issue. Having different ways of recording information and lack of interoperability, the fact that data still are too often in silos, and there are methodological issues to challenge the use. And the New England Journal also picked out this issue about manpower, despite the fact that the Obama recovery plan hoovered up most of the world's talents in this area. They still think that they have a gap. Governance, I think, is the bigger challenge, making sure that you stay within the law, within the jurisdiction that you're working, or the several jurisdictions, if we're starting to collaborate. And that is the last slide. I think that in order to realise the benefits, we need champions of people who will do this. You do need a bit of infrastructure, but crucially, and I think for this audience, there is more of a need for methodologists, analysts, and everywhere we need to work on the type of governance that's needed, and getting stakeholders not just to accept it, but to be enthusiastic about it, that they can see that there is a value in doing this. John Saville, head of the MRC, said that this is all a no-brainer. Well, I hesitate to disagree with Sir John Saville, but I think the idea of using the data is a no-brainer, but it's going to take a lot of brain power to make sure that it can work, to get the full levels of benefits which are there. And I hope that the next few days we'll be able to contribute to all of that. Thank you very much.
Well, thank you very much, Frank, and I'm really pleased that you finished with something about brains, because I guess certainly from my perspective, and I'm sure from yours, you know, we've been pushing and pushing for big data, but unfortunately, there is this view that if you've got big data, you don't have to think, because all of those methodological issues that many of us as epidemiologists have been dealing with for many years, confounding, among other all sorts of errors, there is this kind of simplistic view that, well, if you've got big data, all those things disappear, but you actually just get more precise estimates, but confounded. So I think this whole issue of actually we need good brains. We still need good methodologists. We still need people to think with this data. And I think that's going to be, to me, one of the biggest challenges is as we make this data more and more available, there are a lot of resources are going to be put into making them available to everybody. Whereas somehow, I think, to me, one of the big challenges, can we make them available to the right people who will make the best use of it? Otherwise, it could be a very inefficient use of big data.
I suppose it could be potentially everybody, but they have to be...
That one there.
It could potentially be everybody, but I say the idea is having safe users, people into whose hands you can safely deliver the data so that it will be used. So I think journalists on sensationalist newspapers might be able to comply with that requirement, but maybe not.
So, any questions from... Yes, Tony.
Tony Blakely, fantastic presentation. I've always thought that New Zealand is in a unique position to do stuff, but I haven't quite realised how far we have dropped behind what could be done internationally. There's so much I want to ask you. I'm going to limit it to 3 points with your reflection back to what might be done in New Zealand. The first one is on government versus academic leadership of setting up an institute like this. Where should it sit? If it's in one university drive, I think the University of Dundee, how do you do that in a way that the other universities buy into it? In New Zealand, there's this culture of, damn, Otago, Auckland, Tregear, that type of thing. You need to break that down. First issue that you might want to comment on. Second one is, if I think about birth cohort studies, New Zealand used to have a leadership role in that, we're trying to do another one now, but everybody in the world is doing it. Similar type of issue here, which means that a small country like New Zealand, we need to think about what our point of difference is, that we could do something like what you've done that would be internationally cutting edge. I'd be interested in your reflections of what might be the point of difference that New Zealand might emphasise in an endeavour like this. And my third one is about staging or priorities. So put that in context. We have these big national science challenges at the moment, about $34 million over 10 years, which actually is not a hell of a lot when you spread it out. So we need to stage and prioritise. So for example, would you prioritise the genetics, the biobanking, or just using the routine data? Just your reflections on what the staging priorities might be. Sorry, there's quite a bit there.
It's another 1 hour talk.
Maybe come back over here for that one. So I've got the issue about leadership and people getting credit for things, points of difference to emphasise, and staging of priorities. Well, I guess I was talking to this bit Rod on the way over to the meal last night, that you can achieve a great deal if you're not really all that bothered about getting credit about it. And that's kind of what happened here, that some of the fairly senior people, like Andrew Morris, who's now the chief scientist for Scotland, and Ian Ford in Glasgow, they had very, satisfactory, successful careers. They didn't need to prove anything to anybody. And so they just decided, look, we can do a lot better. We can go onto a different plane if we work together. And I think there was that mood. In some ways in Dundee, there's no choice about that, because the big ones are Glasgow and Edinburgh. So if we ever want to do anything at a bigger scale, we need to think at a Scottish level. So I don't know if there's somewhere smaller. You just have you just have Auckland and Dunedin.
Well, there would be some people who'd say that's good.
I think if the key people in both institutions go to the Research Council or to Health Minister with a combined plan, it's very hard for them to argue against it. They can't divide and rule. Points of difference are you have to know within your system what the key issues are. So here, I would guess the idea of complete capture, unlike, say, in America being so much bigger, but they have these islands of excellence and a sea of sometimes even less than mediocrity in terms of health informatics. You've got Intermountain Healthcare partners, the VA, who can do brilliant stuff, but you have other people who don't have any health service other than just for emergency care. So you can't compete for numbers with California, but you can compete on quality and completeness of some of the data. And your track record. You've got work that's been going on here for decades, which you can build on. And you know already where you have a world lead in some of these areas and where you can work with people in Europe or North America to extend that lead, maintain it. That's all I'd say in points of difference. In terms of staging, again, that's a negotiation and political issue. It's looking where you are, where you want to be, and then deciding what the staging points are on the way. Who we have to persuade to get to the final point. So many of our researchers would not have been all that keen to involve pharma, say, in the early stages. But they realised if we didn't do that, then it was unlikely that the government would come up with a level of funding. So you have to work out a way of working with pharma that satisfies everybody's needs. Is that helpful?
So, yeah.
John Eastwood, public health paediatrician. Following a bit on Tony's question, actually, we've been trying to do intergenerational research, and our data linkage attempts are just very simple, just trying to link the baby with the parents and with the grandparents. And the EMR system we're using in Sydney can't do that. And I think it can be done in New Zealand, but
No.
it's a technical problem which we've been aware of for a very, very long time. And I think if we can solve that problem, it opens up quicker ways of doing transgenerational research rather than waiting 30 years like we've done with the Christchurch studies.
Just to say, we can't do it here either, but I think it's a really key issue.
Okay, well, it was one of the cases that we had. We had one of these ex-professor obstetric dies and widows clearing out garage and discovers records on 27,000 births in garage. And that was all digitised and then linked. And we've gone back from the mothers to their parents and now onto 3 generations further on.
We've got 50,000 now for 2012 in Sydney, and another 50,000 for 2013. But it's a very difficult process. It's requiring a lot of work.
Well, I guess that's the kind of thing where I would say about the community of practice. There are people who have done it, so just saying, well, how did you do it? And what of the things that you did could we do here? And what of the things, that you do we can't do? So we need to think more creatively. But if there are half a dozen people really interested in solving that problem, they'll solve it. It's not an insoluble problem.
Will they do it? The best place to do intergenerational related research is Denmark, because they can link everybody. But there aren't many countries that do that actually have everyone linked. But we'll need to talk to Simon Ross from the ministry about that. Maybe we need an NHI that goes across the whole family. Yeah. Okay, we'll have got time for one more question. Yeah, from James Harris from Pharmac.
It's interesting you're structured for the safety, the 4 levels, categories of access. On the one hand, what's the cost of running that system? And I guess 2 questions. How many cases actually come through to that? And what would actually be the consequences that you didn't have that structure? And on the other hand, what benefit are you blocking by either reducing access to the system or by not allowing an analyst to spot something in the data that would have a real effect for a patient, but they're not allowed to take that back?
Okay, well, I don't know how far to go back with it. I think, I was on the Privacy Advisory Committee for about 3 years, and I kind of found out what had happened from the researcher's perspective before. It's rare that things can't go ahead, that may have to be changed. before it can get permission. So reduce the extent to which patients can be identified, and the research can still go ahead. They were getting about, as I say, 2 or 3 a week, and it went up to about 8 or 10 a day requests to go through whenever the systems all started to increase. The actual cost, I don't think it is that much, because it was a relatively low-level civil servant who was making most of the decision. They had to be a graduate, they had to be fairly smart, and they had a reporting structure. But I would guess that it's probably still under £30,000 or £40,000, a year to run that. Most of the expense might come from the travelling expenses for people to come to the 2 actual Privacy Advisory Committee things a year, where they look at the hard cases in some detail. And then you have quite a range of expertise, several lawyers, but also, say, just members of the public to try to be persuaded. It's basically a red, amber, green system. And most things, if people have followed the benchmarks, are green, and they just go ahead. The data gets released. The amber ones get discussed by email and resolved. The red ones are the ones that come to committee.
So we might have to carry this conversation on after, just because we're running 5 minutes late. And look, Frank, just like to thank you very much for this presentation. Frank is here for the next 2 days.
Yeah.
And so please make sure that if you have questions, Stanley, that you come up and chat to him about it. So if you'd all join me in thanking Frank for